Hi, welcome back to my channel. In this video, I'll be talking about the anti-cancer drugs. So first we will go through the classification and then we'll go through the individual points of all the drugs that are relevant for exam point of view. So starting from the first one, the first class of drugs that we'll talk about is alkylating agents. So alkylating agents. Now in this you further have nitrogen mustards, then you have nitrosoureas, then we have the alkyl sulfonate, then you have something which is called as ethylamine, and then you have the triazine. Alright, then you have platinum compounds, then you have anti-metabolites. Now in anti-metabolites further there are three. So we have folate antagonist, then we have purine antagonist, and then we have pyrimidine antagonist. Alright, then we have certain more. So we have microtubule damaging agents. In this you have two. One is vinca alkaloids and the another is taxane, and you have one more which is estramestin. Okay, then we have topoisomerase inhibitors. So you have one inhibitor and two inhibitors. Alright, and then further we have antibiotics, and then we have miscellaneous drugs. Alright, so this is the broad classification. So starting from the first one, which is the alkylating agents. So in alkylating agents, the first one that I've written is nitrogen mustards. So nitrogen mustards, you have to remember cyclophosphamide, then iphosphamide, chlorambucil, melphalan, and meclorethamine. Then in nitrosourea, you have to remember carmustine, lomustine. Alright, then in alkyl sulfonate you have busulfan, then in ethylamine you have thiotepa, and in triazines you have dacarbazine and temozolomide, and you have something which is procarbazine. Now this is also classified under methyl hydrazine. Okay, then coming on to folate antagonist, so we have our favorite methotrexate and we have p-metrext. Then in purine antagonist we have 6-mercaptopurine, then we have 6-thioguanine, then we have azathioprine, and in pyrimidine antagonist you have 5-fluorouracil, then cytarabine, then we have capricitabine. Okay, now coming on to the vinca alkaloids. In vinca alkaloids you have vinblastine, vincristin. Now here there's this thing to know that vincristin is also called as oncovin. Then taxanes, you have paclitaxel, docetaxel. Alright, then coming into topoisomerase, so the two is etoposide and one is topotecan, irinotecan. Then in antibiotics you can remember doxorubicin, daunorubicin, bleomycin, mitomycin C, actinomycin D. Alright, then coming on to the last one. Now over here we have hydroxy urea, then we have triretinone, then we have L-asparaginase, then we have a lot of drugs like aromatase inhibitors, hormone related, alright, and so on. So we'll just talk about them individually. And I forgot to write the platinum ones. So this we all know: cisplatin, carboplatin, and oxaliplatin. Alright, now this is the basic classification. Now let's talk about the first drug, that is alkylating agents. Now in alkylating agents, first of all you should know that this is CCNS. So what do you mean by this is that it is cell cycle non-specific class of drugs. Alright, so then basically why they are called as alkylating agents is because they alkylate nucleophilic groups on DNA basis. Basically N7 of guanine is most susceptible. Alright, so now let's start. So the first one is the nitrogen mustards. Alright, you remember the names, I hope, cyclophosphamide and so on. So first of all we'll talk about cyclophosphamide. So the cyclophosphamide is converted into aldophosphamide, which acts then is metabolized. So this is the drug of choice for Wegener's granulomatosis. Now it has a degradation product which is acrolein. Now this acrolein is responsible for hemorrhagic cystitis. Now how you treat hemorrhagic cystitis is first of all hydration, vigorous hydration. Then you can give mesna. Now what is mesna? Mesna is mercaptoethane sulfonic acid, okay, and ifosfamide also causes. And then there is mefalin, which I told you. So this drug is responsible for drug of choice for multiple myeloma. Okay, then you had meclorethamine. This is given for Hodgkin's disease. Now the side effects are that it can cause cardiac toxicity, SIADH. Okay, now coming on to the next one. So second is nitroso ureas, carmustine and so on. So in this first of all they are very lipid soluble and they cross the blood-brain barrier, and they're used for the treatment of delayed neutropenia. Okay, now there's this drug which is streptozocin. It destroys beta cells of pancreas, so it can be used in islet cell tumor. Alright, then chlorambucil is used for chronic leukoid leukemia. Alright, then coming on to the adverse effects. Now in this basic category, as I told you, adverse effects are basically bone marrow toxicity and so on. So I'll just write it, bone marrow toxicity. Alright, then coming on to the third one, which is platinum compounds. Now in this there are some points that you should know. So first of all, we have the famous drug cisplatin. Now this cisplatin, it is basically most nephrotoxic, and there's this question: it should always be given in slow IV infusion because then it prevents the intense nausea and acute increase in serum creatinine. Alright, then we have another drug which is the carboplatin. Now this is less toxic than cisplatin. Alright, then when you are administering these drugs, it is important to establish chlorine diuresis prior to cisplatin to prevent renal toxicity. Now there's one more thing, aluminium. It basically inactivates cisplatin, and even for this toxicity you can give more amifostin. Then coming on to anti-metabolites. Now in anti-metabolites, first is folic acid analog. Basic is that they inhibit the thiamidylate synthase. Methotrexate, basically it forms polyglutamates and traps it within cell, so it becomes cytotoxic to neoplastic cells. Now this methotrexate is the drug of choice for choriocarcinoma, acute leukemia, non-Hodgkin lymphoma, breast cancer, then also for cutaneous T-cell lymphoma. Now there are a number of reasons why methotrexate resistance can occur. First is impaired transport of methotrexate to cells, then production of altered forms of DHFRAs, which decreases the affinity. Alright, then increase in concentration of DHFRAs in cell through gene amplification. Then there can be increase in drug efflux transporter. Then it can be sequestered in third space collection, and then it can go to the general circulation, and then it can lead to prolonged immunosuppression. Then kidney function and vigorous hydration is required to inhibit crystallization of methotrexate in renal tubules. Okay, now there's one question more. In intrathecal administration, you basically give it for meningeal leukemia. Okay, and other uses are rheumatoid arthritis, psoriasis, ectopic pregnancy, and so on. Okay, now in methotrexate there are some adverse effects. Alright, so adverse effects, basically burning mouth syndrome, mucositis. Now its toxicity, it can be prevented by administration of N10 formyl tetrahydrofolic acid. We can give folinic acid, citrovorin factor, or leucovorin. This whole thing is called as leucovorin rescue. You can also do alkalinization of urine. In extreme cases, you can do dialysis. or glucarpidase. Okay, then coming on to then we had pre-methotrexate. So this is used for meso mesotheloma. Alright, and you also have one more, which is the praltrexate, and this you give for T-cell lymphoma. Okay, now coming on to the next one, which is our purine analogs. So I'll write it here. So okay, so you have purine and pyrimidine analogs. Now I already told you all the names, right? And these are metabolized by xanthine oxidase. So basically, when you administer it with allopurinol, the original dose is reduced to 1/4. Okay, and they are used for the treatment of acute leukemia, CML. Alright, hairy cell leukemia, and they are kind of hepatotoxic. Alright, then coming on to pyrimidine. So I told you cytarabine and all. 5-fluorouracil is the most important one. So in this, basically they're used for AML. Alright, now over here, these are activated by HGPRTase enzyme. Now you can comment down which deficiency of this enzyme is seen in which condition. Okay, and these are activated by the kinases. Okay, basically they inhibit the DNA polymerization. Okay, then yeah, this much is enough for this. And in this there's one thing, that capecitabine and 5-fluorouracil, they cause the hand and foot syndrome. Now what do you mean by this hand and foot syndrome? Is basically there is erythromyalgia. There is basically tingling of the and numbness of the hands and feet, and there is pain and erythema, and this is treated by uridine triacetate. Okay, then coming on to the next class of drugs. So in this, there's one more question that they ask is about adverse effects. I'll just cover it. So you have cytarabine, which is used for AML. So this basically causes cerebellar ataxia. Okay, then capecitabine, this causes hyperbilirubinemia, and obviously hand foot mouth syndrome. Only hand foot syndrome. Alright.